You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes. You can also follow us on Twitter at ASAMorg and Facebook. Now, let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Sean McNeil, Digital Content Editor for the Journal of Addiction Medicine. Today we're joined by Dr. John McCarthy. He's an Associate Professor of Psychiatry and Volunteer Clinical Faculty at the University of California, Davis. Welcome to the podcast, Dr. McCarthy. I want to first inquire a bit about your academic background and your history in the field of addictions.
Well, I did a psychiatric residency in Colorado, and I was really headed to be a psychoanalyst. I mean, life has its turns, twists, and turns. I got a faculty appointment at UC Davis when I finished, and I was working in community mental health, which was fine, but I was used to, intensive patient care, where I'd talk to the patient. These mental health centers at the time, and I'm sure they all vary, but I was writing 19 or 20 scripts a day and barely seeing the patients. It was something I just didn't want to do. So I went to the department and I said, look, this isn't fitting me. And they said, well, look, we've got this methadone program, and no one really wants to do that. Do you want to take over the methadone program? I said, fine. I took it over. I could actually see the patients. I knew nothing about methadone and heroin addiction. What you get in medical school, and back in the day, was that they got liver disease and abscesses, and you get the medical complications of needle drug use, but nothing particularly about treating heroin addicts. And so that began. I really enjoyed. I had the authority to be able to see the patients when I needed to see them, and have staff, get trained the right way so that I could get good information from the staff. With that done, it became really fun. I enjoyed working in the clinic. I loved it. I worked, until a couple of years ago as a doc in a methadone program.
Fantastic. And what has been more of the focus of your work recently?
Well, until a couple of years ago, I ran a methadone buprenorphine treatment system in Sacramento. We had 3 clinics, and I don't know, by the time I retired from clinical practice, we had, 1,300 patients. So we were seeing the tidal wave of opiate addiction for sure. The specialty that I've had is pregnancy and opiate dependence. So that's pretty much been my focus of research for quite a while. This last paper was data I collected over a period of a year on serum levels in pregnancy. So I used the data. I had no idea when I started, Sean, what the hell methadone metabolite ratios were good for. I'd never heard of them. I didn't know anything about them, but I had ordered serum levels all the time on pregnant patients because I wanted to know the best measure of metabolism I could get, and I used trough serum levels. And I'd follow them during the pregnancy every 4 to 6 weeks, and then repeat maybe 2 or 3 times postpartum, because I learned that postpartum period is a very critical period to watch the mother, because the serum levels just take off.
Right. And I was even surprised how quickly they returned to their baseline metabolism and perhaps even overshot that previous level of functioning.
Yeah, I think what was happening is the return to baseline. No one's ever really, I think there's a couple of studies that suggest maybe 6 to 10 weeks for this P450 system to return to the non-pregnant state. And some of them, it returns really quickly, at least, if not fully, very quickly, within maybe a week or two after delivery. The amazing thing that I found out of this article and writing it and learning about enzyme induction, believe me, I always hated the P450 system because I never knew what effect it was going to have. We have all these medicines that are P450 substrates, and when you give them with methadone, you just don't know. You learn through experience. The drug that stands out is rifampin. It had methadone patients with TB get put on rifampin, and they are it's like giving them naloxone. They're in withdrawal very rapidly. Rifampin has a dramatic effect on it. The antidepressants I could never figure out, even though the science says that they should have some effect on metabolism. So either the induction or the inhibition, when paired with other drugs, is that P450 system. And like I said, that we've never had a good way of knowing what it's doing directly.
And regarding that correlation, it looks like the metabolism of these women picked up during the second and third trimesters.
All during pregnancy. The ratios were, I believe it was, I'd have to look at the article, but I believe the first trimester was a ratio of 6.1. And the lower the ratio, the faster the metabolic rate. And, baseline populations are 11 or 12. And then the second trimester was 5.9. So there wasn't a significant change between first and second. It did go a little lower. And the third trimester was 5.1. So the significant change was between the first and the third trimesters statistically. But when we looked at individual patients, some patients were metabolizing, they hit this ultra rapid, you read the article that you can categorize these MMRs into ultra rapid and extensive, the 4 categories. So 4 and below is ultra rapid metabolism, which happens with methadone patients, but it's only like a 5%, maybe 10%. That's another issue we can talk about, but the ratio of 6 is definitely rapid, and then the transition back to the postpartum period, jumping back up significantly.
Do you feel that the strategy of using their metabolic ratio to inform the dose you give them, do you feel like that actually improved their clinical outcomes?
Well, I think so. But, I think it was, as a tool, freestanding tool alone, maybe I couldn't say that. But I could say that working closely with the moms and using those ratios allowed me to demonstrate to them and to me the need for changing the dose and the dose regimen. The dose regimen is really important. This is a dependence producing medication, and in pregnancy, for some of these ultra-rapid metabolizers, methadone becomes like a Vicodin. It's like a 6-hour drug, which is completely the opposite of what you want.
Okay. Do you hope that any of this might inform current protocols so that more clinicians are checking this ratio?
I would like to see that. I think that, the use of serum levels is not a standard of care. Maybe this MMR paper will give people an added idea about the value of them, the value of serum levels.
Well, Dr. McCarthy, thank you so much for joining us today on the podcast. Thank you for discussing your work and particularly this recent study of yours.
Well, I'm glad to do it, Sean. I really am. It's been a kind of a life passion, so no problem on this end at all, and appreciate talking to you.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.